So our last speaker is connecting with us from United Kingdom. He's a well-known personality in Sri Lanka who had been visiting this country last 2 decades. Over 20 years he has been coming on and off, and he's a great friend of the College of Oncologists. He's none other than Peter Hoskin. He is the consultant in clinical oncology at Mount Vernon Hospital, Northwood, United Kingdom, since 1992. He is also the professor in clinical oncology at University College London. And his research interests have ranged from palliative radiotherapy to the use of radiosensitizers and brachytherapy. He is the current editor of Clinical Oncology and section editor for brachytherapy and member of the editorial boards of Radiotherapy and Oncology for the Journal of Oncology. Without much ado, let me invite him to be connected with us for his video presentation on advances in adjuvant radiotherapy in endometrial cancer.
Thank you for asking me to talk today on advances in adjuvant radiotherapy in endometrial cancer. The staging of endometrial cancer will be familiar to you all. Stage 1, restricted to the uterus with degrees of myometrial invasion. Stage 2, invasion of the cervical stroma. Stage 3, extending outside the uterus. And stage 4, into the bladder or bowel, or stage 4B, metastasis. The importance of this is in defining risk groups, which define in turn our various approaches to adjuvant treatment. And here we see the most recent ESMO-ESGO-ESTRO consensus, dividing patients into low, intermediate, high, and advanced endometrial cancer. In terms of adjuvant radiotherapy, it is the stage 1 to 3 cases that will be considered for adjuvant radiotherapy after hysterectomy. You see there the low risk group, stage 1, grade 1 to 2, with less than 50% myometrial invasion and no lymphovascular space invasion. Intermediate, with grade 1 to 2, more than 50% myometrial invasion, what we term stage 1B. High intermediate, which is grade 3, stage 1B, which may or may not have LVSI. Or lower grade disease with definite evidence of lymphovascular space invasion. And high risk, stage 1, grade 3, more than 50% invasion, that's stage 1B, regardless of LVSI, or stage 2 disease, or stage 3 with no residual disease. Non-endometrioid cancers are also included in the high-risk group, particularly the serous, clear cell, or undifferentiated carcinomas and carcinosarcoma. So what is our management of these cases? And what are we trying to achieve? Predominantly, it will be pelvic control, although of course an impact on overall survival would be very welcome for many patients. Here we see a series from 20 years ago, 725 patients, not given postoperative radiotherapy, and you see there are a range of cases, predominantly low and low intermediate risk. And they describe 29 out of 73 pelvic relapses occurring in the vagina. The overall relapse rate you see there is about 10%. And of the vaginal relapses, 2/3 occur at the apex and 1/3 distally in the suburethral region. Here a much larger series, a more recent series from the United States, 2,691 women. The median follow-up is 6.1 years, and the recurrence rate here is 7.2%, with a local recurrence rate of 3.7%. Predominantly, again, low and intermediate risk patients, although predominantly stage 1A. What you see here is the impact of recurrence. And in the bottom left-hand plot, you see that the likelihood of survival plummets dramatically with recurrence. And here you see patients who recur, and here you see patients who do not recur. So recurrence, whether local or distant, does have an impact on survival as well as patients' quality of life. On the right here, you see the difference between survival after vaginal relapse and after pelvic relapse. You saw in the table of risk factors that lymphovascular space invasion is a significant risk factor. And here you see one of the major pieces of evidence for this, a pooled analysis of the PORTEC-1 and PORTEC-2 trials. And here you see the analysis of that large patient population by the presence or absence of lymphovascular space invasion. Here on the right, the probability of distant metastasis. And you see here with substantial LVSI, it's around 30%. With no LVSI, it's very much lower at less than 10%. Focal LVSI is somewhere in between. And if we look on the right at pelvic regional relapse, we see again substantial LVSI is a strong predictor for pelvic relapse. Focal LVSI and no LVSI actually have no increased risk. And the impact of treatment in the PORTEC-1 and 2 trials, which we'll go into in some detail shortly, but it's important to note that in terms of pelvic recurrence, both vaginal vault brachytherapy and no adjuvant treatment have the same outcome, and that is a pelvic recurrence rate of just over 30% there. External beam radiotherapy is the one treatment that significantly reduces pelvic regional relapses in patients with LVSI. And hence you will see that LVSI is a strong indicator for using external beam radiotherapy rather than vaginal vault or. So when we're considering adjuvant post-hysterectomy radiotherapy for localized endometrial cancer, we have a number of options. We can opt for surveillance. We can offer vaginal vault brachytherapy. We can give external beam radiotherapy and perhaps chemoradiation. And we can give the same with vaginal vault brachytherapy. So what is our choice based on? Well, for very good risk patients, it is perfectly reasonable for them to have observation. And here's a very nice study, a randomized trial from Sweden, low-risk patients, although some stage 1B patients, but grade 1 or grade 2. And you see there two treatment groups, the one on the left having surgery alone, the one on the right having adjuvant vaginal vault brachytherapy. Vaginal vault brachytherapy reduces vaginal relapse, but this is not significant despite a large number of patients, and an increase in urinary toxicity. And overall, therefore, no benefit for the patient. And one would say with these very low levels of vaginal relapse, not a clinically significant or statistically significant difference. So this may well be adequately watched. Vaginal vault brachytherapy then is best reserved for intermediate risk patients without LVSI. External beam with or without chemoradiation, the high intermediate risk with LVSI, or the high risk patients. And external beam and vaginal vault brachytherapy, the high risk patients with stage 2 disease, that is with vaginal invasion. Sorry, it's cervical invasion, which carries a higher risk of vaginal relapse. So we run through the PORTEC studies very briefly, which are our largest and best evidence base. We can go back to the PORTEC-1 study now 20 years ago, which were high-risk patients. You see there, stage 1C was into the outer third of the myometrium before the new staging system came in, and these would now be stage 1B, grade 2 or grade 3, and they were randomized to receive either external beam radiotherapy, delivering 46 gray and 23 fractions, or no adjuvant radiotherapy. And what you see there in the bottom left-hand corner is the impact of radiotherapy on pelvic relapse. This was the group having radiotherapy. This is the group having no radiotherapy. Obviously, a very substantial impact. The other important message that came out of the PORTEC-1 study was that age is an important predictor for outcome in endometrial cancer. And it's perhaps counterintuitively younger patients that do better. So here we see patients under the age of 60, and here we see patients over the age of 60 and over the age of 70. So it is not the case that older patients with endometrial cancer do not require adjuvant treatment. Indeed, they have a greater need and a greater risk of relapse than do the younger patients. We now have a Cochrane review of the 3 trials that have looked at adjuvant external beam radiotherapy for high-risk patients. You see the results here for overall survival, and what you note on this forest plot is that the results are largely along the line of equipoise. In other words, there is no impact of adjuvant external beam radiotherapy on overall survival. What we do achieve with adjuvant external beam radiotherapy is a reduction in local relapse. So this is local regional recurrence, and you see here consistently the forest plot, and this is the cumulative analysis with a hazard ratio there of 0.36 reduction in the likelihood of pelvic relapse. So external beam radiotherapy in these selected high-risk patients has a significant effect on local relapse. Does it have an effect on survival? By and large, the received wisdom is that it doesn't, but there is some data that says perhaps in a population situation it does. Here's one of the SEER database analyses. We know that there are shortcomings in SEER database, but nonetheless it is a large population-based study. Here you see 12,284 patients with stage 1 endometrial cancer, pure adenocarcinomas, endometrioid adenocarcinomas. And what you see here is the bottom line, which is patients having no radiotherapy. In fact, the majority, 7,600. And here you see the patients who got pelvic radiotherapy or pelvic radiotherapy and brachytherapy or brachytherapy alone. But in all the radiotherapy groups, there was an improvement in overall survival. And because of the large numbers, this is statistically significant. Briefly then, the PORTEC-2 study. The PORTEC-2 study took intermediate risk patients, you see the inclusion criteria in the box on the left, and randomized them to receive either vaginal vault brachytherapy or pelvic radiotherapy. You see there the 2 vaginal brachytherapy schedules, 21 Gray and 3 fractions, high dose rate, or 30 Gray as a single dose, low dose rate. And you see here the 3-year overall survival was no difference between the 2 arms, 84% in both arms. And the 3-year disease-specific survival was no different either. So once again, no impact on survival. If we look at the patients, we see they were predominantly intermediate risk. Stage 1C or 2A. Remember, 1C is outer third, that is now stage 1B. Stage 1B were middle third, which will be partly 1A, partly 1B in current nomenclature, but a very small number of patients, so of no great consequence. And the majority were over 60 years, and almost all patients grade 1 or grade 2. So correctly, grade 3 patients would be classified high risk and offered external beam radiotherapy. Here you see the 10-year results, and what we see is that overall there is not a big difference. This is the cumulative probability of vaginal recurrence, and this is the bottom part of this curve magnified up to 5% here, and you see here no difference between external beam radiotherapy and vaginal vault brachytherapy for vaginal recurrence. There is a difference in pelvic recurrence. You see it here. This is the vaginal vault brachytherapy group, which had about a 5% pelvic recurrence, compared with the external beam radiotherapy group, where there were very few events. In fact, you can see here on the curve only 2 blips causing events, and so a very low probability of pelvic recurrence with external beam radiotherapy, and obviously a statistically significant result. When we look at other parameters, distant metastasis-free survival, we see no difference between the 2 arms, and overall survival, again, we see no difference. So the price of external beam radiotherapy here, or the payoff, is that you have a slightly lower risk of pelvic recurrence. What is the impact on the patient? Well, there's been a lot of quality of life data produced by the PORTEC-2 study. What you see here is that if we look at bowel function, so this is diarrhea score, this is limitation in daily activity by bowel function, this is need to remain close to a toilet, this is fecal leakage. The blue line is always higher than the red line, statistically significantly so. In other words, you get very much higher rates of bowel upset with the external beam radiotherapy compared with the vaginal vault brachytherapy. Similarly, lesser differences, but always the vaginal vault brachytherapy providing a better result than the external beam radiotherapy result. This is global health, quality of life, social functioning, role functioning, and sexual functioning. In all these parameters, the outcome is in favor of vaginal vault brachytherapy, providing better quality of life. And each of these curves, although not such a big difference as with the bowel function, each of these curves is statistically significant. There was also patient-reported symptom scores in the PORTEC-2 study, and this shows quite nicely the difference between the two treatment arms, vaginal vault brachytherapy on the right, external beam radiotherapy on the left, and the darker the grey, the higher the score, going from not at all, this would be a little, this would be quite a bit, and then the dark black line very much. And I think for each of these parameters, diarrhea, bowel urgency, urinary urgency, sleep deprivation from urinary frequency, fecal leakage, limitation due to bowel function, need to remain close to a toilet, limitation of daily activities from urinary symptoms, you can see that there's very much more dark grey on the left-hand column than the right-hand column. In other words, external beam radiotherapy delivers perhaps a slightly lower pelvic recurrence rate, but substantially greater upset for the patient in terms of global health and particularly bowel and urinary function. So the conclusions, there's no difference in overall survival or disease-free survival. The results of the external beam radiotherapy arm are comparable to the PORTEC-1 and other studies, Aztec and GOG99. In other words, this was not a result of a particularly good external beam radiotherapy arm or particularly poor brachytherapy arm. These were comparable results to other published literature. Brachytherapy was effective in preventing vaginal relapse. There's more pelvic relapse after vaginal vault brachytherapy, but this is usually associated with distant relapse, and the quality of life was greatly improved with just vaginal vault brachytherapy. And therefore, in this patient group of intermediate risk patients without characteristics of the high intermediate risk group, in other words, without grade 3 disease or LVSI, then these patients are best served with vaginal vault brachytherapy. And then we move on to PORTEC-3. PORTEC-3 looked at chemoradiation, and here you see the headline results that there was an impact on overall survival, which is now statistically significant by using chemoradiation and adjuvant chemotherapy rather than just radiotherapy alone. This was in high-risk patients, and you see here again, this is translated into a failure-free survival in favor of chemoradiotherapy, 76% against 69%. And if we look at some subgroup analyses, these are unplanned subgroup analyses, so statistically not so secure, but nonetheless we see the greatest effect in stage 3 patients. You see here 5-year overall survival, 78% compared to 68%, statistically significant. And for serous cancers, again, you see a big effect on overall survival, 71% for chemoradiation compared with 52.8, say 53% with radiotherapy alone. So for stage 3 and serous cancers, chemoradiation and adjuvant chemotherapy has a very much superior effect over radiotherapy alone in terms of overall survival. And if we look at toxicity and quality of life, we see, of course, with the radiotherapy and chemoradiotherapy group, a difference. Here's the chemoradiotherapy group, and you would expect there to be much more toxicity during chemoradiation and adjuvant chemotherapy. But the reassuring thing is that if we take the baseline of each group here and we look at 24 months later, or indeed 12 months later, by and large patients come back to baseline. There's very little change for the control group, but even in the chemoradiation group we see patients here coming back to baseline at 12 and 24 months. So yes, there is more acute toxicity, but late toxicity does not seem to perpetuate. Toxicity and quality of life, yes, there is more effect on physical functioning, on social functioning, on fatigue, on global health score from the chemoradiation group compared with the radiotherapy alone group. But what we see here, in fact, is that at 12 months and 24 months, if we take the global health score, they are, in fact, both running along together, and there's no further adverse effect beyond 12 months from radiation, but a better survival. So chemoradiotherapy plus adjuvant chemotherapy is, from PORTEC-3, the standard for high-risk patients. There is an alternative view, and that is to say, well, do we need the radiotherapy? This was the GOG 258 trial, which was published last year. What we see here is that comparing chemotherapy with chemoradiotherapy, we see no advantage of the chemoradiation added to the chemotherapy. So the conclusion of this study was that therapy may not have a role. However, when we look at the patients who got radiotherapy, we see that there is actually a statistically significant reduction in vaginal recurrence, in pelvic or para-aortic recurrence, and in distant recurrence. And therefore, it does seem that adding in radiotherapy has a much greater effect, particularly on local and local regional recurrence, and adds to chemotherapy as well as the effect of survival, which we achieve giving chemotherapy for the high-risk patients. What has happened with all these studies? Well, we do see a switch from external beam radiotherapy to brachytherapy since the PORTEC-2 data, which showed that brachytherapy was as good but with better quality of life compared with external beam radiotherapy in the intermediate risk groups. Here you see the brachytherapy arm very much higher in the 1BG3s and the 1CG1s and the 1CG2s. Remember, C is effectively 1B, that's outer myometrial third. And where is it all going? Well, the direction at the moment is to look more and more for personalized care, and this is based on the molecular classification of tumors. Here you see an analysis from the PORTEC-3 trial looking at various molecular classifiers, P53, which will be familiar to you all as a tumor suppressor gene. The POL mutation, POL is a DNA polymerase epsilon. The MMRD, which is a mismatch repair deficiency, and then another group which had no specific molecular profile. And you see here that the patients with the POL mutation, in fact, do very much better than the others. The mismatch repair and P53 run along very similarly, and the no specific molecular profile ones are the ones that actually appear to do worse. And you see that's the case for both relapse-free survival here and for overall survival in this plot on the right. So it is possible to identify risk groups within the high-risk group with molecular classification, and you see there indeed a group with the POL mutation which probably don't need any further. Here in the PORTEC-2 study, a similar analysis, and again looking particularly at molecular changes. P53 again you see for pelvic recurrence, for distant recurrence, for endometrial cancer, survival, so disease-specific survival, mutated cases having a hazard ratio of about 3, and for the L1 CAM, that's a cell adhesion molecule marker, again you see a much higher hazard ratio for pelvic recurrence, distant recurrence, and for core-specific survival has a ratio of 5 if you have that high levels of that mutation. The basis of this, we have PORTEC-4, which is the current trial, and this is using molecular classification to define treatment. Standard arm is vaginal brachytherapy, and then patients are selected into a favorable, intermediate, or unfavorable group. The unfavorable group receiving external beam radiotherapy, the intermediate group vaginal brachytherapy, and the favorable group just observation. It is based on the molecular profile of the tumor. The pole mutation, remember, are the good ones, and these are favorable and just watched. Mismatch repair deficiency, if they don't have that, and they don't have the CTNNB wild type mutation, which is a beta-catenin gene, they are also favorable. Those that have the mutation go into intermediate, as do those with mismatch repair genes, and the poor risk patients, the unfavorable ones getting external beam radiotherapy, are those with substantial lymphovascular space invasion, the p53 mutation, or more than 10% of the L1 CAM, the cell adhesion molecule expression. So we're moving more and more into a molecular phase of disease classification, stratification, and that guiding our adjuvant treatment. Of course, the results of this study are some way off, and we will see if this actually impacts on patient outcome. One last thing, one last analysis from the PORTEC studies. We're giving women significant amounts of radiation to the pelvis. Is this of any great danger over and above the organ-related side effects? And they have looked very carefully at the probability of second cancers. And you see here reassuringly that whether patients receive radiotherapy or not in these studies, there is no increase in the probability of second cancers. So I hope I have given you a very brief and very rapid overview of adjuvant treatment in localized endometrial cancer. We can offer no treatment for the low-risk patients, vaginal vault brachytherapy for the intermediate risk patients without high-risk parameters, including LVSI, external beam radiotherapy for the high intermediate risk patients with LVSI and high-risk patients, and external beam radiotherapy and vaginal vault brachytherapy for the high-risk patients with cervical involvement to receive the vaginal vault brachytherapy. PORTEC-3 study shows us that chemoradiation and adjuvant chemotherapy should be considered particularly for patients with stage 3 disease and those with serous carcinomas. Thank you for your attention.
Thank you very much for your splendid and comprehensive lecture. And shall we move on to the Q&A session? Is it okay to you, sir? Hello. Can you hear me, sir? Can you hear me?
I can hear you very well.
Okay.
Yes, I can hear you.
Yes. Now we move on to the Q&A session. I will forward to the first question. And do you recommend adjuvant chemoradiation to all high-risk group or only the serous or stage 3 population, considering PORTEC-3 trial, sir?
Currently, we offer it only to the stage 3, and the serous carcinoma, we have a slightly different schedule where we give carboplatin at the moment, but I think the evidence from PORTEC-3 would certainly support giving the full chemoradiation and adjuvant carboplatin paclitaxel schedule for serous carcinoma as well. So yes, stage 3 and serous carcinomas, we would follow the PORTEC protocol.
Okay, so next question is, if suppose the one patient is medically not fit for surgery, and what is the radiotherapy dose you recommend, sir?
Well, we would treat those very much like a cervical cancer. So we would treat usually with external beam. Sometimes the difficulty with those patients is being sure of the stage. MRI, if they are able to have an MRI scan, because often the comorbidities also preclude them from an MRI scan. But if they're able to have an MRI scan, then that gives us some reassurance perhaps that they may be just stage 1 or stage 2. Sometimes it will show you evidence of lymphadenopathy pushing them into the stage 3 category. So we would treat them on the basis of MR staging. A stage 1 carcinoma, we would treat like a cervix, so we would treat with external beam radiotherapy. And because we're not sure of the staging and not always sure even of the grade, we would include the lymph nodes, treat with a standard pelvis that would receive 45 gray and 25 fractions, and then we would use intracavitary brachytherapy. The problem with these patients, it's sometimes quite challenging because they will have a large uterus, a large cavity, and a single intrauterine tube often doesn't give good coverage of the entire myometrium. And so I personally use Hayman's capsules. I know other groups use the Y applicator, but I would be looking at a uterine cavity applicator to ensure we had good coverage of the entire myometrium. So we would do this with image-guided brachytherapy, and you can do that with CT as well as with MR because you just need to see the entire uterus. The volume, the CTV for your brachytherapy is the serosal surface of the uterus, which you can usually define easily on CT or MR, and use the intracavitary sources to deliver that. And I would give the same as I would give for a carcinoma of the cervix, 4 times 7 gray, using the same constraints as we would give for carcinoma of the cervix. The problem treating the uterus, of course, is often the bowel is much closer to the volume, and indeed often coming down onto the fundus of the uterus. So sometimes, more often, you are limited by the tolerances. So 45 gray, 25 fractions external beam, and then intracavitary brachytherapy to give 28 gray and 4 fractions.
Provided by that may be the local regional disease. And the second question is, what is the recommendation on sentinel node lymph node dissection biopsy for the stage 1 disease? They ask about the stage 1, the importance of the sentinel node biopsy dissection, pelvic dissection.
Yeah.
Yes,
I think it's difficult. I think in endometrial cancer, we're not certain still. There is some evidence that it can be useful. Our surgeons certainly don't use it routinely, but I have been to meetings where it's quite strongly advocated. But certainly our practice, and I think generally in the UK, sentinel node biopsy is not used for uterine cancer.
Thank you, sir. And the next question is, if the patient's histology says grade 2 tumor with stage 2A, but no lymphovascular invasion, what is the place for prophylaxis, pelvic lymph node and para-aortic lymph node irradiation?
For those patients, I would not give prophylactic irradiation. Those patients went into PORTEC 2, and I would just give those patients vaginal vault brachytherapy. I think they are a difficult area. The 1B G2, the 2A G2, they do have a slightly higher risk, and you can justify giving external beam radiotherapy. And you know that the results of PORTEC 1 suggest to us that that may be, in fact, in the older patients. And that's always a more difficult decision because there's always a tendency to try and treat more aggressively the younger patients and try not to impose a lot of treatment on older patients. But the PORTEC data certainly shows us that it's the highest risk of relapse increases with age. So in general, I would offer these patients vaginal vault brachytherapy.
Suppose if the patient has only para-aortic nodes only, will you offer surgery, this para-aortic node resection for the patients with selected para-aortic lymph nodes?
You mean at relapse?
Yes, sir. Relapse.
Yes. Yes, it depends on the fitness of the patient, because often these patients are not the fittest. And it would depend on the para-aortic, the size of the para-aortic nodes. Small volume para-aortic nodes, I think we would treat comfortably with radiotherapy, and you can boost the para-aortic nodes to 60 gray, and that is often, well, in most cases, is adequate to control nodal disease. I mean, we do have some surgeons who will do para-aortic lymphadenopathy, and I think if you can adenectomy. If you can do a para-aortic node dissection, then that is probably preferable, but they would still need post-operative radiotherapy.
Okay, thank you very much. The next question is that POTEC 3 overall survival was not only shown for the stage 3 patients, but not the stage 1 and stage 2 high-risk patients. So would you still apply chemoradiotherapy for stage 1 and stage 2 high-risk patients?
No, we would just give post-operative radiotherapy for those. So pelvic radiotherapy alone.
Okay, sir. The next one is how to manage stage 1A endometrial cancer, but the type is papillary serous carcinoma, age 73-year-old lady.
So in those patients, we would give carboplatin. Although it's stage 1A, we know that the natural history of serous carcinoma is more aggressive, and we know that the pattern of spread, the natural history, is for the cancer to become transcelomic and develop within the abdominopelvic cavity. So in those cases, we would offer 6 cycles of carboplatin, and that would be on the basis that certainly in early stage ovary cancer, serous cancer in the ovary, we do get better results with carboplatin. And we would then give vaginal vault brachytherapy because there is still a risk of vaginal vault recurrence, which we want to avoid. So 6 cycles of carboplatin followed by vaginal vault brachytherapy.
Okay. The next question is, what is the recommended brachytherapy dose after EBRT for stage 2 endometrial cancers?
After EBRT, it would be, well, people use many different schedules, but I would use 8 gray and 2 fractions, so 2 times 4 gray. And that really is based on the rectal tolerance, because once you've given 45 gray to the rectum, the anterior rectal wall, you have limited tolerance there. And really the prescription dose is going to be your anterior rectal wall dose. So we would give 8 gray and 2 fractions on top of 45 gray.
Okay, so a lot of questions coming up from the audience, so I will give one by one. What is the role of adjuvant chemo with or without brachytherapy in high-risk endometrial cancer?
Well, I think the role is as in the POTEC 3 data. So the role is in stage 3 and serous carcinomas. I wouldn't give it otherwise.
Okay, so do you recommend adjuvant chemo-RT even for serous stage 1 carcinoma?
If it's stage 1B or 2A, yes, I would. I think 1A is slightly different. But once you've got stage 1B, particularly if you've got LVSI as well, then you have a significant risk of abdominopelvic contamination.
Okay, sir. The next one, for the pelvic relapse, a case after EBRT, what would you recommend? Salvage surgery or re-radiation? That means in the relapse, pelvic relapse, after the definitive treatment, would you recommend salvage surgery or the irradiation? Re-irradiation, it means.
So it depends on the pelvic relapse. So pelvic relapse covers a vast spectrum of disease. So the common pattern is relapse at the vaginal vault. Surgery for that is quite extensive. It's total vaginectomy, which most patients and indeed most surgeons prefer to avoid. The other common pattern is the periurethral nodule. So if we look at relapses, vaginal relapses, about 2/3 are at the vault, 1/3 are lower down the vagina, typically in the anterior vaginal wall around the urethra. Those patients we would treat with a combination of external beam radiotherapy and brachytherapy. Sometimes a small periurethral recurrence we would treat with just brachytherapy. If there's pelvic sidewall recurrence, that's much more difficult. But again, it's also much more difficult for the surgeon. And I think surgery has a very limited role in those patients. And again, we would consider external beam radiotherapy and If they had previous external beam radiotherapy, then of course that becomes much more difficult. It's retreatment. We might consider chemotherapy, but we know that chemotherapy response rates in a previously irradiated pelvis are much lower than you would get in unirradiated tissue in distant metastases, and typically of the order of 20% or so, which is very low. So they are difficult cases, and we would choose them one by one. But if it's operable, I would certainly encourage a surgeon to operate. If not, then we would do our best with further radiotherapy.
Thank you, sir. The next questions to answer over to you, sir, Dr. Karunaratna.
There are a few other questions as well waiting for you. I don't know how pragmatic this question is. How to manage stage 3 patient who wishes to retain her fertility?
Yes, I don't know how practical that is either.
Okay.
Well, you can't.
Can't,
That's the straight answer.
Okay.
You could attempt to preserve the ovary. Again, there's risk in that because we know endometrial cancer will spread to the ovary. But if it's a very young woman and you're under pressure, you could, with her understanding, preserve an ovary, or you could go for egg harvest and in vitro fertilization. But the uterus will not support a pregnancy, so she would also need a surrogate mother. So as you say, the practicalities are somewhat challenging.
Okay. The next question is, what is the ICR dose after chemotherapy in stage 1 serous cancer?
The brachytherapy dose,
yes,
is 21 gray 3 fractions. We have a standard vaginal vault dose. It's based on the PORTEC 2 protocol, and that is your level 1 evidence for vaginal vault brachytherapy now. And the dose was 21 gray 3 fractions.
Okay, thank you. If we are using vaginal brachytherapy for brachytherapy alone, instead of external beam radiotherapy, what is the recommended dose?
Well, it's just, yes, 21 gray 3 fractions. If we're talking about microscopic disease, we're talking about post-hysterectomy, then 21 gray 3 fractions. There are other schedules out there. I used to use 22 gray in 4 fractions. Other people will choose other fractionations, but 21 gray 3 fractions is the evidence base, and I think that's the most widely used, certainly in Europe.
Okay, then in cases where in endometrial cancers, if there is no cervical involvement, would you treat these patients with stage 2 cancers? Would you treat these patients with vaginal brachytherapy? Cervix is not being involved in stage 2 cancers, but it's only the upper part of the uterus is involved. Would you still treat them with vaginal brachytherapy?
No, although I'm a little puzzled because stage 2, the definition of stage 2 is cervical involvement, invasion of the cervical stroma.
We'll turn this question to this way.
That would be stage 1.
If there is a deeper myometrial invasion in a fundal cancer, not involving the cervix,
yes. Yep.
And would you use vaginal brachytherapy?
Yes, if it's stage 1B, grade 2, I would do. If it's
even if the cervix is not involved.
Yes.
Yes.
Because we know that those patients will still have a risk of vaginal vault recurrence. It's lowish. I mean, it's at the order of, well, if you take the PORTEC studies, it's at the order of less than 10%, 8%, I think. It falls down to about 2 or 3% with vaginal vault brachytherapy. And it's not trivial to have to treat vaginal vault recurrence. So it's quite a difficult problem, quite distressing for the patient. And therefore, it's worth preventing that small percentage with what is quite a simple treatment. And I appreciate Sri Lanka, your resources for brachytherapy have been quite limited, but it is a simple treatment. It can be carried out very quickly and very easily. And certainly we would offer those patients vaginal brachytherapy.
In stage 1 disease, where the cancer is confined to the endometrium only, can you treat with high-dose progestogens in favoring the fertility sparing? Progestogen, yeah, the cancer is confined to the endometrium, which does not have lymphatics at all in the endometrium. Can you use high-dose progestogen to reverse the and to retain the fertility?
I don't think you can reverse the cancer once it's developed. You can control it certainly, and certainly in some elderly inoperable cases, we have treated those with progestogens, and it can be very effective. But you have to remember the response rate to progestogens in endometrial cancer is only of the order of 30 to 40%. So only 1 in 3 patients will achieve some response, which is quite a disturbing number that won't receive response. In other words, 2 out of 3 patients, it won't work at all. You can use it, and certainly for patients with atypia, then progestogens can push the differentiation back the other way. I don't think once you've got an established carcinoma that happens, but you can certainly control it. I wouldn't see it as a definitive treatment. And again, I think if the object is pregnancy sparing, my understanding, which is limited, is that high-dose progestogens would also be suppressing ovulation. And again, you have an abnormal uterine physiology, you have an abnormal endometrium. I don't know that would be very good at sustaining a pregnancy. So I think that's a high-risk strategy, because then you have the risk of not controlling the cancer, still needing surgery with perhaps a more advanced cancer, and not having achieved what was the original intent, which was to retain some fertility.
If I put this question this way, a patient who is having endometrioid grade 1 disease, well-differentiated cancer, confined to the endometrium only, no myometrial invasion on the MRI. Can those patients be treated with high-dose progestogen as a process of reversing the cancer and then give a fertility treatment later on?
Well, to answer that, one is how
patients like
how
that.
do you know it's only?
Yeah,
I mean, they can be. The likelihood of success is small, and the risks are substantial if you allow the cancer to become more advanced. But the other question is, how can you be certain that it is just confined to the endometrium?
Yeah, we do MRI scan.
Yeah, I don't think MRI will be 100% accurate, particularly when it's more superficial. So even if you look at the positive predictive value of MRI in that situation, it's about 80–85%. Again, that means 1 in 6 patients you get it wrong. And so you're adding other risks of not being successful, partly because of misleading staging on the MRI, and then because of all the other adverse factors that are related to the use of high-dose progestogens. So it's, you might say it's worth a try, but it's, and I can sense someone wants to try very hard, but I think it's important you see all the risks in it.
Yeah. So is there any place for hormone treatment in adjuvant setting?
No.
No.
Many years ago, I took part in a trial of adjuvant hormones. And there was a big international trial. I think it was run from Australia, and it was negative. And it's never been repeated, but I think there's absolutely no evidence. And you know, adjuvant hormones means high-dose progestogens. They are not non-toxic. I've had patients become very Cushingoid on progestogens. Indeed, I had one patient going to heart failure because of water retention. So I think you've got to have strong evidence for that sort of treatment, and there is none.
Okay, the last question for you. How much radiotherapy, what is the radiotherapy dose to be delivered in case of recurrent endometrial stage 4A with bladder invasion and bilateral hydronephrosis? Oh.
How much worse can it get?
Yeah.
That sounds like an anterior exenteration to me. Well, again, but it depends, doesn't it? It depends if you've had previous radiotherapy or not. If you've not had previous radiotherapy, then you treat them de novo, like any uterine cancer. So you give 45 Gray and 25 fractions, you give brachytherapy, you take that to 28 Gray and 4 fractions, but you accept that there's a significant risk of that patient getting a fistula and actually needing some sort of urinary diversion. Before that, of course, you want to relieve the hydronephrosis, so you'll either want some stents or nephrostomies. So it's not a trivial exercise, but it's still potentially curable. Now, the difficult ones are the ones who've had previous radiotherapy, of course, and it comes back in that situation. So you've already given 45 Gray in 25 fractions or thereabouts. And the issue of retreatment is more difficult because if you don't give a high dose, you don't control it. If you do give a high dose, you will almost certainly have a fistula that won't heal and potentially more serious problems in the bowel. And I think those patients, you really do have to have a serious discussion with a competent and good exenterative surgeon, because I think probably anterior exenteration is the best treatment in that situation.
Thank you, Peter. Thank you very much for connecting with us early morning in London, 7:30. And on behalf of the College of Oncologists, let me show our appreciation to you. Thank you very much.
Thank you. It's great to see you all again.